Good afternoon. This video is to improve the knowledge of differential diagnosis for the Heent system. We're going to start with the differential diagnosis of different types of headache. Headache is pain of any part of the head, including the scalp, the face, including the orbitotemporal area, and interior part of the head as anatomy. Headache is one of the most common reasons patients seek medical attention. Remember, pathophysiological wise, in general, headache is due to an activation of pain-sensitive structures in or around the brain, skull, face, sinuses, as well as teeth. Etiological wise, before we start the differential diagnosis, headache may occur as a primary disorder or secondary to another etiology. Primary headache disorders include migraine, cluster headaches, also includes chronic paroxysmal hemicrania, tension type headache as well. Secondary type of headache has numerous causes that we'll discuss in a brief moment. Let's start with primary headache. Primary headache, we'll discuss first migraine type of headaches. Migraine is an episode of primary headache disorder that the symptoms typically last 4 to 72 hours and may be severe. Pain is often unilateral, throbbing, worse with exertion, and accompanied by symptoms such as nausea, sensitivity to light, photophobia, as well as others. Patients, 25% of them have auras, usually just before the symptoms of headache start. The pathophysiology of migraine is a neurovascular pain syndrome that altered central neuronal processing, is a type of hyperexcitability and cortical excitation. Involves most of the time the trigeminal vascular system, but it could also be associated with painful inflammation in the dura mater. Potential triggers for migraine headache could include drinking red wine, skipping meals, excessive afferent sensitive stimuli such as flashlights, strong odors, weather changes, sleep deprivation, stress, as well as hormonal factors and certain foods. So if we go over the symptoms, again, location is unilateral. The quality is throbbing, aching. The timing is 1 to 2 hours, even though it could last up to 72 hours. And the main associated symptoms are nausea, vomiting as described, and photophobia, phonophobia, and it could be or not associated with aura. Fluctuating estrogen levels are potentiators of migraine headache. Many women have onset of migraine at menarche. They have severe attacks during menstruation that could be confused with a premenstrual episode. Oral contraceptives and other hormones could also increase the pain. Remember that an aura is basically a symptom that precedes an attack, and aura auras could also be present in seizure disorders. It's basically a temporary neurological disturbance that most of the time affects sensation, but it could also affect balance, muscle coordination, speech, or vision. They could last minutes to an hour, and most of the time is the same symptom that precedes the headache, or in neurological system class that we'll have after this presentation, it could also be associated with seizures. The most common aura involve a visual symptom. Basically, patients complain of flashes, lights, bright scotomas. They could also complain of speech disturbances and paresthesias. Very much confused sometimes with the TIA or stroke symptoms, because the patients could have dysarthria, they could have aphasia, they could have ataxia, even confusion, and it's only an aura. Patients could have acute migraines or chronic migraines, and that could last episodes of more than 15 days. Other associated symptoms besides the aura, patients could have a very rare type of migraine, which is called hemiplegic migraine, which is sporadic, causing unilateral weakness, and again is confused with TIA or stroke. Diagnosis of migraine is basically due by clinical symptoms. Remember that it's a severe type of pain, is unilateral. You have to rule out other etiologies that could cause red flag for secondary type of headache. For example, transient ischemic attack or strokes. So if a patient has, for example, fever or altered mental status or any focal weakness, you would rule out a migraine and think mostly about secondary type of headache. The treatment already was discussed in pharmacology, so remember that headache is a severe type of headache, so even though you could give acetaminophen or NSAIDs or caffeine-based analgesics, most of the time they won't work. So you could prescribe triptans or ergotamines. In addition to that, you have to eliminate the triggers, and including foods and wine, and relieve stress. So behavioral intervention is very important. In addition, other medications that are adjuvants to treatment are, for example, prochlorpromazine, suppositories, as well as opioids. Other adjuvants are beta blockers, lithium, calcium channel blockers. But remember, the main stem of migraine headache treatment for severe attacks are ergotamines and triptans. Remember that the contraindication for triptans and ergotamines are patients that have history of hypertension or coronary artery disease, because they're potent vasoconstrictors, and that increases the likelihood for CAD and severe hypertension. Now let's talk about tension headache. Tension headache is basically sensitivity of the pericranial muscle tenderness. Patient most of the time has an episodic type of headache. Very common, it's actually one of the most common types of headache, is classified as mild to moderate. The pain is usually vice-like. Patient complains of having frontal occipital, sometimes like a band-like around the head. So it could be bilateral. It's not unilateral. It's bilateral. It's band-like, frontotemporal. It could actually radiate completely up to the occipital area. So it goes completely around the head. It is not commonly associated with nausea and vomiting, not even photophobia or phonophobia. Patients also complain of having neck pain, eyes being tired because of stress, because of too much work, because too much time in front of the computer, etc. So if you elicit the factor of patient having too much work or a stressful episode in life, most likely the headache is related to tension. But remember, the pattern would be bilateral, and patient describe of having something tight around their head. The pain is steady, is non-throbbing. It is not associated with nausea and vomiting, not commonly associated with photophobia and phonophobia, even though it has been described, but the percentage is very minimal. Diagnosis, again, triggers that could elicit tension type, stress in life. Treatment is to try to do psychological intervention, relaxation, stress management. Try not to use any drug, but if would be used, basically would be targeting mild type of headache, which is basically acetaminophen, Tylenol, or NSAIDs. Now, cluster headache. Cluster headache, the pathophysiology is basically an autonomic activation, the same as migraine. The type of headache is also unilateral, but instead of being unilateral on the face, is basically retroorbital. So it could be temporal, periorbital, but most commonly the patients are complaining of eye pain. Could be associated with ptosis, lacrimation, rhinorrhea, or nasal congestion. Cluster headaches are primarily seen in men, normally between 20 to 40 years old. The pathophysiology is unknown, although we already have said that has, since its periodicity, suggests hypothalamic dysfunction. Alcohol intake triggers the cluster headache, but the pattern for cluster is that the headache comes in group, is an episodic event. Patients complain of headache in the summer, or it's a pattern that they complain of headache in the winter, is commonly seen at the same time of the year. That's the reason why it's named cluster. Attacks often occur at the same time each day. The pain awakens the patient from sleep. Very important factor to differentiate. When the attack occurs, the pain is always unilateral and occurs on the same side of the head in the orbital temporal distribution. It is excruciating. It could occur between 30 minutes to an hour, but is commonly abrupted. Patients are agitated, they're restless, they have bizarre behaviors. Sometimes they bang their head on the wall. And the autonomic features that accompany the headache is basically nasal congestion, rhinorrhea, lacrimation, flushing, etc. The treatment, as you could see, this is a severe headache, the same as migraine. So the same treatments apply. You could give triptans, you could give ergotamines, but it's been in research studies that using 100% or high flow oxygenation improves the cluster headache. And the reason is because the high flow oxygenation improves vasoconstriction. Now, secondary types of headache. We'll discuss analgesic rebound, acute glaucoma, sinusitis, meningitis, subarachnoid hemorrhage, giant cell arteritis, and trigeminal neuralgias. So we'll start with analgesic rebound. Analgesic rebound is identified as a syndrome that occurs commonly in headache sufferers who overuse abortive medications to treat the headache. For example, patients that are constantly using Tylenol, constantly using NSAIDs, constantly using triptans or ergotamines. They overuse these abortive medications, and as a result, they have increasingly frequent headaches that become unresponsive to those abortive or prophylactic medications. Over a period of weeks, the patient's episodic migraine or tension headache becomes more and more frequent until they become chronic. This daily headache become increasingly unresponsive, as I said, is probably underdiagnosed by a healthcare professional because they keep increasing the abortive medications without realizing that what the patient is going through is a rebound effect. Sometimes also is seen when you withdraw suddenly the analgesics. The clinical manifestations is basically like a transform pattern of any type of primary headache. So assuming the same characteristics of migraine, now they're changing in quality and intensity, or the tension headache has also changing quality and intensity. So that's the reason why it says previous head pattern. So whatever head pattern, headache pattern that you had before, now has increasing intensity or change. The common analgesics that produce rebound headaches are Tylenol, as I said, any caffeine added to NSAIDs. If the patient is using butalbital, such as Furinol, opioids, ergotamine, triptans, etc. Treatment for analgesic rebound headache is basically the discontinuation of the overuse or abused drugs and complete abstination from them for a period of at least 3 months. Many patients, of course, cannot tolerate outpatient discontinuation of these medications and will ultimately require hospitalization in a specialized inpatient headache unit. Now let's talk about glaucoma. Glaucoma, remember that this is an increase intraocular pressure of more than 21. Glaucomas are primary, open angle glaucoma, and closed angle glaucoma, which is an emergency. Remember that this is a syndrome of the optic nerve damage associated with anterior chamber angle being closed and elevated of the intraocular pressure. The pathophysiology, let's go to the next slide and then we go back. Remember that the aqueous humor is basically produced in the ciliary body, and it goes through the pupil to the posterior chamber, and then goes to the anterior chamber, and it gets drained in the trabecular meshwork and the canal of Schlemm. If at any point of this pathway of production and drainage there is an obstruction or outflow occlusion, glaucoma will take place. Risk factors associated with glaucoma: older age, family history of glaucoma, black race is for some reason is more prevalent, systemic hypertension, diabetes, patients that have any type of esotropia or exotropia are at higher risk of open angle glaucoma as well as closed. Symptoms most commonly associated with glaucoma. Let's go back. Is basically pain, an intense pain inside or around the eye. Usually the patient becomes aware of visual field loss only when the optic nerve atrophy is marked. Patient also complain of having missing stairs when they go up or down. They have difficulty driving. Examination findings include an obstructive open angle when you do a fundoscopic examination, or when you use gonioscopy or measure the pressure of the intraocular compartment is greater than 21 millimeters of mercury. Now, if we go back to the slide, I basically included the normal anatomy of the fundoscopic examination, and basically the optic nerve is normally slightly vertical, elongated like a circle. You know, it's a perfect circle with centrally located depression, which is the cop. The optic nerve cells comprise the neuroretinal rim, and the disc margins are very knitted with the nasal blurring, which is completely normal. This is what we explained in class, that the veins are thicker and they're opaque compared to the arteries, which are thinner, and they have a better projection of the light, so they're brighter. If we go back to the prior slide to be able to continue the symptomatology of open angle or closed angle glaucoma, patients have a steady aching and severe pain in the eye, which you have to be able to differentiate between cluster headache and glaucoma. But remember, these patients have symptoms associated with vision loss. Now, since we already saw the normal anatomy of the fundoscopic examination, let's talk about the pathological findings of glaucoma. In this slide right here, you have signs of moderate glaucoma, including thinning of the neuroretinal rim with an increased cupping. If you remember the actual optic disc, it was a perfect round disc. This one has the angle, this vertical angle is increased compared to this horizontal angle. So instead of being a perfect circle, now is an oval. On top of that, the actual margins of the disc, they look more pronounced. That's called cupping. You can also see notching of the rim. I don't know if you're able to see a notch right there. They have a wedge-shaped dark areas that reflect retinal nerve fibers right here in this area. In the other slide, you're able to see a retinal hemorrhage that could also be associated with open angle and closed angle glaucoma. Basically, this is a splinter hemorrhage right here, and another one at this level. Okay. So let's continue with the actual PowerPoint presentation of different types of headache. So remember that diagnostic evaluations for open angle glaucoma basically is you do a visual testing, a visual field testing, and patients would have difficult in the central vision. Is also diagnosed by a fundoscopic examination with the vision, the findings that I just described, cupping. Also measuring the pressure of the intraocular compartment, which it would be greater than 21. The treatment is basically, remember in pharmacology, that to be able to decrease the intraocular pressure, the initial drugs would be prostaglandin analogs. You could also use beta blockers. In addition, you could also use acetozolamide, which is basically a diuretic at the proximal tubule. You could also use surgery, which is laser trabeculostomy, trabeculoplasty, and also filtration procedures. If you remember types of carbonic anhydrase inhibitor, which is the acetozolamide or Diamox, could be used. In addition to that, you could use beta blockers. Beta blockers include timolol. Other examples are betaxolol, cartilol, but the most common is basically timolol. Examples of prostaglandin analogs are latanoprost, as well as bimatoprost. So all the medications that finish in toprost, such as bimatoprost, latanoprost, travoprost, all those are prostaglandin analogs. Remember, your first line of treatment will be prostaglandin analogs and beta blockers. You could also use osmotic diuretics for emergencies such as in closed angle glaucoma, which are mannitol or glycerin. You could also use alpha-2 agonist. You could use also miotics such as neostigmine or physostigmine. You could use other miotics such as cholinergic agonist for actually the eye exam, which is pilocarpine or carbachol. So now let's talk about sinusitis. Sinusitis is basically an inflammation of the sinuses, as you know. And symptoms include nasal obstruction, congestion, rhinorrhea, facial pain or pressure. So basically the patient complains of a headache on changing position. So when the patient tries to bend their body, it hurts. When they're trying to cough or sneeze, it hurts. It could be associated with malaise, fever. It could be frontal, maxillary. It's rare to be able to feel pain in the ethmoid or sphenoid. The most common two are the superficial, frontal, or maxillary. The quality of the headache is basically aching and severity, variable. And the clue here is headache hurts the most when I change my body position. Remember that sinusitis is most of the time, etiological wise, viral. The most common viruses are rhinoviruses, influenza, parainfluenza, Haemophilus, etc. Bacteria wise, Haemophilus influenza, Moraxella catarrhalis, Klebsiella, but it could also be associated with Pseudomonas. Diagnosis is by clinical manifestations. Rarely you need to use x-rays or CAT scans or MRIs. So when you go to your specialty classes, you're going to realize that the guideline says never use x-ray or CAT scans or MRIs unless the patient has red flag symptoms such as toothache or facial pain or fever greater than 102, even though you see otherwise seen in practice. Remember the guideline for treatment for sinusitis basically is amoxicillin and amoxicillin clavulanate as a second line. If you are hypersensitivity reaction type 1, you use microlides antibiotic. You could also use fluoroquinolones. But if you're not hypersensitivity reaction type 1, so basically if you're allergic to penicillin but you have only had a rash or mild erythema or only pruritus, you could use third generation cephalosporin, so cefdinir or cefotaxime or augmentin. Patients could also have chronic sinusitis, and risk factors for that is basically having allergic rhinitis, nasal polyps. Patients with immunocompromised disorders such as diabetes, HIV, they tend to have more recurrent episodes of chronic sinusitis. Now let's talk about meningitis. Meningitis is basically an inflammation of the meninges that patients actually have focal manifestations of focal neurological findings. Remember that in next class you're going to be talking about meningism, and that is basically having nuchal rigidity, having positive Kernick and Brusinski. In addition to that, patients could have papilledema, and those are signs of meningism. The location is basically generalized. Quality is severe, steady, throbbing type of headache. It could be associated with vomiting, but this vomiting most of the time is projectile vomiting. Patients with meningitis could have viral meningitis and also bacterial meningitis. Diagnosis of meningitis is basically by CSF analysis. And in your specialty areas, you're going to talk about how to differentiate in the CSF um, viral versus bacterial. Treatment for meningitis is basically depending on the most common bacterial infection. Um, Remember that you have strep pneumonia, you have Haemophilus influenza, and Neisseria meningitis. And even though for Neisseria meningitis, penicillin G is the best choice, combination of third-generation cephalosporin, such as Rocephin or Ceftineer, cefotaxime, ceftriaxone, with vancomycin are most of the time the first line for all of them. In addition to that, you could use fluoroquinolones. You could use meropenins as an alternative for treatment. You could use also sulfate drugs such as Bactrim. Have in mind that macrolides antibiotics do not cross the blood-brain barrier, so it's not a best choice for these patients. Subarachnoid hemorrhage basically is due to rupture of an aneurysm. The symptoms include a sudden severe headache, usually with loss of impairment of consciousness. It could also be associated with secondary vasospasm, causing a focal brain ischemia. Patients would have signs of meningism. They could present with persistent headache or obtundation. But the quality and severity of the subarachnoid hemorrhage is most commonly described by the patient as the worst headache of my life. Diagnosis of subarachnoid hemorrhage is best done by CT scan of the brain without contrast, MRI, MRA. You could also do CSF analysis, and we'll discuss the findings in neurological. The pathophysiology again is basically due to either vasospasm or a rupture of an aneurysm. The headache is severe, peaking within seconds, associated with loss of consciousness. Is very sustained, not alleviated by anything. Seizures is a possibility of associated symptoms. Patients could have signs and symptoms of meningism, vomiting, obtundation, etc. Now let's talk about giant cell arteritis. Giant cell arteritis involves predominantly the thoracic aorta, basically the large arteries emerging from the aorta in the neck. Symptoms and signs may include headache, visual disturbances, tenderness, pain in the jaw during chewing. So most of the time it's temporal, it's throbbing, generalized, persistent, severe. Is basically a vasculated focal. Is a disorder of the elastic tissue of the artery. Most of the time is associated with temporal arteritis. Again, patients could have associated symptoms of fatigue, malaise, but the main symptom is a throbbing headache, temporal. They could also have visual disturbances, diplopia, scotomas, and also they have a sudden, brief period episode of complete vision loss, which is called amaurosis fugax. Diagnosis is basically by biopsying the temporal artery. And the treatment, the main stem of treatment would be steroids. You could also use low-dose aspirin to prevent the episode, but the main treatment will be steroid. Trigeminal neuralgia. Trigeminal neuralgia is basically a paroxysmal lancinating facial pain due to compression of the trigeminal nerve. The symptoms basically occur along the distribution of the division of the trigeminal nerve. Most often is the maxillary, but it could be the ophthalmic or it could be the mandibular. It's basically shock-like, stabbing, burning. It's a neuropathic type of pain. Diagnosis is basically by clinical signs and symptoms. Sometimes the patient has a prior episode of ophthalmic herpes, so they develop a postherpetic neuralgia along the fifth cranial nerve distribution. And because it's a neuropathic pain, it's basically treated with the medications that are used for neuropathic pain. So you could use anticonvulsants such as Tegretol, you could use Trileptal, you could use Neurontin, you could use Dilantin, you could use Leoracel. In addition to that, remember you could also use your SSRIs. If the medications above don't work, you could use craniectomy or ablation therapy. So now let's talk about differential diagnosis of red eye pain. Red eye. So we're going to be talking about conjunctivitis, subconjunctival hemorrhage, corneal injury, acute iritis, and glaucoma, which it was already discussed. So now let's talk about conjunctivitis. Conjunctivitis is basically a redness of the conjunctiva or conjunctiva. It could be allergic conjunctivitis, viral conjunctivitis, acute bacterial conjunctivitis. You could have perennial conjunctivitis, which is basically a seasonal allergic as well. Let's talk about allergic conjunctivitis and how to differentiate those. So basically, patients with allergic conjunctivitis, they have conjunctivitis on both eyes, not in one eye. The symptoms is basically lacrimation, itching, discharge, but this discharge is clear. Remember that is basically due to the mast cell being degranulated. So you have hyperemia well distributed among both eyes. Okay. Compared to, well, let's talk about treatment first before we move. The treatment is basically antihistamines. And let's talk now about the difference on conjunctivitis related to bacterial. So bacterial conjunctivitis, remember that the most common is Staph aureus, strep pneumonia, Haemophilus influenza as well. So basically the patients have unilateral redness, even though then moves to the other eye. Eventually, it's very contagious. Allergic conjunctivitis is not contagious at all. The discharge is basically yellowish or purulent. Okay, patients could have associated petechial subconjunctiva or hemorrhages, could be associated with photophobia
a sensation of a foreign body in their eye. And the treatment will be completely different. It's basically antibiotic treatment. And if you remember in pharmacology, the antibiotic treatment, the first line of treatment would be your fluoroquinolones, topically, of course, ophthalmic, and the choices are moxifloxacin. You could also use trimethoprim with polymyxin. The gonococcal conjunctivitis, which is rare, you could use ceftriaxone, 1 gram IM. Fluoroquinolones are no longer recommended for this. In addition to that, you could use bacitracin, gentamicin, ophthalmic solution. You could use for chlamydia azithromycin or doxycycline. For ophthalma neonatorum, for family nurse practitioners in the pediatric area, you could use erythromycin. If the ophthalmic neonatorum is due to gonococcal, even though the prophylactic is erythromycin, you could also use ceftriaxone. And for chlamydia infection, it's exactly the same, erythromycin. In addition to that, you could also have conjunctivitis due to chemical conditions, but that would not be part of our discussion. So now let's talk about subconjunctival hemorrhages. Basically, this is a benign disorder. Okay, it's leakage of blood. So it's basically a result from a minor local trauma. It could be due to straining, sneezing, coughing. It's basically spontaneous. It's a bleeding, is a leaking of blood outside due to high pressure. Patients would have diffuse hyperemia. It's very well distributed. The margins are very knitted. And that blood is absorbed spontaneously, usually within 2 weeks, without any treatment. To expedite reabsorption, you could use vasoconstrictors or topical corticosteroids, but it's rarely used. So basically the treatment for subconjunctival hemorrhage is nothing. The pain is absent, there's no discharge, and the significant risk factor is, again, trauma or coughing or vomiting, etc. Now let's talk about corneal injury. Corneal injury, basically a patient have a history of scratching or abrading or using contact lenses, cutting the cornea by accidental or having been involved in sport related activities, etc. Patient basically have an injury of the cornea, and patients complain of pain, which is moderate to severe, tearing, photophobia, sensation of a foreign body, greedy feeling. The symptoms are worsened by exposure to light, by blinking, by rubbing the injured cornea. The diagnosis is basically by, first, the history of the trauma, and second, basically is by applying fluorescent, fluorescein liquid, and do an ophthalmoscopic examination. First, for the patient to allow you to do this examination, you have to provide an anesthetic drop. So most of the time you apply like propakaine or tetracaine, and then the fluorescein, and you're able to see the actual abrasion, and we have a picture in the actual PowerPoint. The treatment for it, although patches, topical antibiotics and mydriatic agents. Traditional has been used in patients with corneal abrasion. Treatment recommendations they have evolved. Now the current recommendations stress the use of topical or oral analgesics and topical antibiotic. So the actual patching is discouraged. Examples of analgesics, you could use Voltaren solution, ophthalmic solution, of course. Topical antibiotics that you could use, or bacitracin ophthalmic solution, or ciprofloxacin ophthalmic solution, etc. You could use also erythromycin or ofloxacin, which is basically the same solution for conjunctivitis. Eye patching is no longer recommended for corneal abrasion. It has been studied in research that actually causes more pain than benefit. And also, in addition, the patching results in decreased oxygen delivery, increased moisture, and higher chance of infection than using analgesics, antibiotics, or mydriatic agents. Now let's talk about iritis. Glaucoma, we're not going to discuss glaucoma again because we already discussed that in the prior PowerPoint. Iritis is basically an inflammation of the iris. The etiology is idiopathic, but it could be traumatic, it could be infectious. The most common infectious process are due to bacterial infections, such as, again, Haemophilus influenza, strep, and staph. It could also be associated with traumatic disorders. It could be associated with autoimmune disorders. So patients with sarcoidosis and scleroderma and lupus, they could have iritis, and even more complicated with uveitis. But remember, the mechanism of trauma is believed to be with a combination of microbial contamination and an accumulation of necrotic products at the site of the injury, producing iritis and uveitis. The actual pattern of the red eye is ciliary injection. Pain is moderate. There's no discharge. And it's an emergency, since it's basically most of the time produced by an infectious process, bacterial, viral, or even TB. Now, what's the best approach for red eye pain? Patient comes with a red eye, and you ask the patient, do you have pain or not? If the patient has eye pain, you have to rule out the most common disease process that produce severe pain. And those are acute glaucoma, uveitis, and iritis. Keratitis as well, but we never discussed it. If the patient has no pain but has blurred vision, you ask them, do you have any type of photophobia? If the patient has photophobia, you have to refer to the ophthalmologist, because photophobia as well as eye pain is associated with ophthalmological emergencies. If the patient has discharge, if the discharge is watery, remember, if it's watery, it's most likely related to allergic or viral conjunctivitis. If it's allergic, you give antihistamine. If it's a viral condition, basically it's a watch for and waiting episode. If it's a bacterial, then we already discussed the most common treatment for bacterial conjunctivitis. And remember, the discharge will be purulent. These are, again, examples of treatments for conjunctivitis, as well as infectious process such as iritis and uveitis. Examples of fluoroquinolones, aminoglycosides, and other antibiotic treatments. This is just picture-wise to be able to differentiate types of conjunctivitis. Conjunctivitis, if you basically look, is coming from the
bulbar conjunctiva and palpebral conjunctiva up. And that's the main difference with iritis, because you will see in the picture of iritis that the actual red comes from the actual iris down and never reaches the palpebral conjunctiva. Subconjunctival hemorrhage, that is a demarcated, knitted subconjunctival, blood leaking out, and does not cause pain. Most of the time is perceived by the patient when they look in the mirror or because it's told by another person, but they never feel any sensation or any pain, no discharge whatsoever. Corneal abrasion or injury. Remember that I told you that patient has a history of trauma, or because they went to sleep or they rubbed their eye with contact lenses on, and the diagnosis is basically done by anesthetizing the area with an ophthalmic solution, putting fluorescein, so the eye is like that yellowish, bright yellowish because of fluorescein. This is what I explained to you about iritis. Remember that the actual redness comes from the iris, from the umbus down. It radiates to the outside, and it never reaches the palpebral conjunctiva. Glaucoma. Patient with glaucoma, they tend to have fixed and dilated pupil. And of course, eye pain, unilateral, and when you measure the pressure or when you do gonioscopy, the pressure will be elevated more than 21 millimeters of mercury. Patients also complain of visual fields and loss of vision or scotoma. Glaucoma, I already gave you another visual representation of Copic. Now let's talk about vertigo. Vertigo is a very common manifestation. There are different types of vertigo. You have peripheral vertigo and central vertigo. Peripheral vertigo or benign paroxysmal positional vertigo, which is one of the common and most frustrating complaints that are brought to the general health practitioners. There are 4 types of vertigo. Dizziness. You have vertigo, you have lightheadedness, you have presyncope, you have delirium. The most prevalent type is vertigo, which is basically a false sensation of motion. To be able to do differential diagnosis of vertigo, you have to basically ask the patient history-wise. History alone reveals the diagnosis in roughly 3 out of 4 complaining of vertigo. The difference between peripheral or central vertigo is the next task, to be able to determine whether the patient has peripheral or central, and the key information is coming from the history. Duration, timing, associated symptoms, specifically neurological symptoms and hearing loss. Characteristics that distinguishes peripheral and central vertigo will be discussed now. You need to be able to determine if the patient has nystagmus or not. If the patient has hearing loss or other manifestations centrally, such as nausea, vomiting, etc. So let's talk about severity. Knowing the severity of vertigo over time is very helpful. For example, if the patient have acute vestibular neuritis, the initial symptoms are very severe. In Meniere's disease, the attack of vertigo increase with intensity and severity, and then lessen later on. So let's talk about benign paroxysmal positional vertigo.
It's basically an episode of vertigo that occurs with certain head positions. So the patient complains that every time they change position, like extending the neck or looking down or going to tie their shoes, they have vertigo. It's associated with nausea, vomiting, and nystagmus. And basically, the pathophysiology of benign paroxysmal positional vertigo is the imbalance of otolith. The otolith are basically calcium deposits in the semicircular canals that are accumulated and they are maldistributed. So every time the patient changes position, they get displaced in the semicircular canals and the patients experience vertigo. So again, this one is triggered when the patient head moves. So when they're rolling over in bed, when they're bending over to pick up something, the vertigo lasts only for a few seconds to minutes. They tend to peak in the morning, so when the patients try to get out of the bed, nausea and vomiting may occur, but hearing loss and tinnitus does not occur. Diagnosis is basically based by characteristic of the symptoms. You could also do maneuvers that are in your PowerPoint, which are the Dick's Hole Spike maneuver. Is a provocative test and is basically treated by the Epley maneuver, and is also a picture in your PowerPoint. Labyrinthitis is basically an inflammation of the labyrinth. It could be purulent, associated with bacterial infection. It could be viral as well. Is sudden, does not have affection of hearing loss or tinnitus, the same as benign positional paroxysmal vertigo. Is diagnosed by a CT scan of the temporal bone. And remember, treatment is basically with antibiotic treatment to avoid meningitis, because remember the labyrinth is the internal ear and is very close to the brain blood barrier. So the treatment for that will be ceftriaxone. Meniere's disease. Meniere's disease is basically a sensory neural disease that is also cause fluctuating sensory neural hearing loss. Meniere's disease pathophysiology is basically due to pressure and volume change at the level of the labyrinth. It's also said that the endolymph suffers a high drop, meaning that there is high fluid producing pressure in the labyrinth. Risk factors are associated with familial, meaning is genetic, pre-existing autoimmune disorders, patients with asthma, allergies, etc. It peaks 20 to 50 years old and is more common in females. This one is associated with tinnitus and hearing. Actually has a triad of vertigo, hearing, and hearing loss, which is sensory neural, and tinnitus. It could also be associated with nausea and vomiting and nystagmus. The patient experiences a sudden attack of vertigo that usually lasts 1 hour to 6 hours. Is associated with diaphoresis, unsteadiness of gait, tinnitus, buzzing, roaring. It is not related to body position or motion. Patients have sensory neural hearing loss. I cannot stress that more. And the treatment for that is basically antiemetics, antihistamines, low salt diet, because remember, it's a problem of volume and pressure at the level of the labyrinth. So it tends to be self-limited, but if you limit the amount of salt in your diet, it could be helpful. In addition to that, other treatments could be anticholinergic therapy, as well as prednisone. Now, drug toxicity. And when I discuss drug toxicity, most of the time we're talking about the aminoglycosides that produce ototoxicity. And these are streptomycin, urneomycin, even though vancomycin is not an aminoglycoside, is in the classification of ototoxic drugs that could, all of them, produce renal insufficiency as well. Other medications that could produce ototoxicity are chemotherapy, Lasix, salicylates as well. So patients would have an insidious onset because they have been with the treatment for a long time or more than 15 days. They do have hearing loss because this is an ototoxicity being produced and it's sensory neural. They could have tinnitus, but it's rarely present. And remember, they have the history of being exposed to either aminoglycosides, vancomycin, or chemotherapy drugs such as cisplatin, diuretics such as furosemide, salicylates, etc. And in addition, we will be discussing central vertigo. And central vertigo basically is sudden in onset. Hearing loss as well as tinnitus is not affected. And the vertigo most of the time comes from anatomy distortion of the brain. Could be associated with intracranial hemorrhages or tumors or any intraparenchymal disease process that is compressing other structures in the brain. Patients, depending on the location of the damage, could have dysarthria, ataxia, and other sensory defects. Now let's talk about ptosis. Ptosis is basically a drop or paralysis of the elevator muscle or the eyelid. Most of the time it's due to a damage of the oculomotor nerve, even though the ophthalmic could also be involved. It could be congenital, it could be associated with trauma, it could be associated with disease process that affect this cranial nerve. And those are brain tumors, diabetes, myasthenia gravis, inflammation, etc. Patients could also have acquired ptosis from Horner syndrome, vascular diseases, etc. Drugs that could produce ptosis, high doses of opioids, such as morphine or oxycodone, also pregabalin or Lyrica could produce ptosis. Entropion is basically an inward or inversion of the eyelid inside. Is caused by an age-related tissue relaxation, but it could also be infectious due to blepharospasm or infection of the eyelids. Maybe also associated with ulcerations and scarring, seborrheic dermatitis, etc. But most of the time, entropion and ectropion are produced by H. So if you look, the eyelids are inside and they actually irritate
the sclera and the cornea, producing a red eye.
Entropion, on the contrary, is an eversion. So entropion is inversion, ectropion is eversion. It's also caused by age-related and palsy of the sixth cranial nerve, associated with tearing, dry eyes, and patients have to use lubricants all the time. To be able to treat that, the same as entropion, it could be done by surgery. Episcleritis is basically damage of the sclera, is self-limited as well. Is localized inflammation of the scleral vessels. May be a nodular, as is shown here, just a nodule with projection on the vessels. It's very self-limited, as I said, but it could be associated with autoimmune disorders or viral conditions such as herpes zoster. Now let's talk about ordeolum and chalazion. Ordeolum and chalazion are basically an infectious process. It's a sudden onset of swelling of the eyelid. Ordeolum is basically due by an staphylococci infection or an abscess, and chalazion is a non-infection obstruction of the meibomian gland. So again, this one, ordeolum, is the stye. Okay, this one is staph. Most of the time, staph aureus. It's red, it's painful. On the contrary to chalazion, is a non-infectious process of an obstruction of the meibomian gland and extravasation of lipid material into the soft tissue. It's basically a granuloma. It's non-painful. Okay, so the symptoms, difference among both. The chalazion, again, is the eyelid is swollen. Patients have tenderness. Sometimes it drains. Patients could have blurred vision, but slight. Ordeolum, again, is non-painful, even though because it's a big lipid material, it could drop the eyelid, and because it drops the eyelid, basically obstruct the pupil, and patients could complain of blurred vision as well, and decrease eyesight. But just because of that. So treatment for ordeolum, basically hot compresses, antibiotic treatment, systemic or ophthalmic. You could use dicloxacin, you could use erythromycin. For chalazion, most of the time the hot compresses won't work, so you have to do incision and curettage and use triamcinolone. Xanthelasma is basically deposits of lipids. Is a yellowish circumscribed flakes that are associated with hyperlipidemia. Dacryl cystitis is basically an obstruction of the lacrimal glands and produces redness, painful, tender area. Again, patients are complaining of tearing and regurgitation of materials coming out of the punta. Arco senile is basically a manifestation of age. As you could see, there is a white border that appears as we age. It's a thin grayish white that does not require any treatment. Cataracts are basically an opacification of the lens. The main symptom is basically gradual. There is painless. Patients complain of blurred vision. Diagnosis is done by ophthalmoscopic and slit lamp. Patients complain of central vision loss. The earliest symptoms are loss of contrast, halos around the lights. So basically, patients look at the lights and they say, "Oh, I see a colorful starburst or glare around the light." They're not complaining of photophobia; it's painless. And the degree of blurring is due to the maturity of the cataract. You know that the diagnosis is basically done by dilating the pupil, and sometimes when it's mature enough, you could see it at a glance. And the treatment is basically surgical intervention. Differences of pinguella and pterygium. Basically, the pinguella is yellowish triangular nodule. So if you see here is a nodule, and the difference with pterygium is that is triangular thickening of the bulbar conjunctiva. And both processes are benign. Thank you very much, and that will be the end of this PowerPoint.